Greetings and welcome. Thank you for joining me today. I'm Neel. I'm an associate clinical professor of medicine at the UC San Diego School of Medicine, where I serve in the Department of Medicine in the Division of Geriatrics, Gerontology, and Palliative Care. My specialty is in the realm of dementia care, and I'm a member of a group called the San Diego Alzheimer's Project, which exists to try to do what we can to increase education and awareness of Alzheimer's disease and other related dementias, as well as provide best practice guidelines for how to screen, evaluate, and take care of patients with dementia. Today, I'd like to talk with you about an overview of screening guidelines for Alzheimer's disease and other related dementias. And during this time, we'll also be talking about some tips and strategies for how to address questions that will inevitably arise when we're doing screening evaluations, such as, what do I do about this? If I'm concerned about my memory, what should I be doing? How should I be trying to protect it? So we'll be going into all of those details during today's lecture. I have no financial disclosures or no financial relationships to disclose. And the reason that we're talking about this is that Alzheimer's disease is a highly prevalent disease. It's estimated that 100,000 San Diegans live with Alzheimer's dementia as of 2020, and it's been counted as the fourth leading cause of death. 1 in 3 people over the age of 85 have Alzheimer's disease, and these numbers are only expected to grow. Additionally, these numbers are just based on the actual diagnosis coding for Alzheimer's disease, but we know that there's a lot of Alzheimer's disease that goes unrecognized, undocumented, undiagnosed. So these numbers are likely horribly underestimating the prevalence of this disease. And we see that in that we spend a ton of money taking care of patients with Alzheimer's disease throughout the United States. $214 billion is spent annually on care for these patients. 1 of every $5 of Medicare spending goes to Alzheimer's disease. As far as who manages it, as you can see, the large majority of Alzheimer's disease is managed not by subspecialists, but by family practice and internal medicine practice primary care physicians. Within San Diego, for instance, these are the numbers as of 2015 of physicians in these different specialties. And what we see is that there are a lot of primary care physicians, but there are not a lot of subspecialists that can take care of patients with dementia. 121 geriatricians, 153 neurologists, 621 psychiatrists. And of that, even smaller numbers of them actually take care of Alzheimer's disease on a day-to-day basis. So whether we like it or not, the care of Alzheimer's disease falls largely on primary care practitioners. But unfortunately, we don't spend a lot of time in medical school and residency education talking about how to actually evaluate for and take care of patients with Alzheimer's disease. More and more, though, we're realizing how important this is and how important it is to know how to do it and how to do it well. And so that's what we at the Alzheimer's Project are here to try to do, is to educate on how to do it well. And so today in particular, what we're going to be talking about is the first portion of that, which is screening for memory loss. We'll be talking about when to screen, what instruments to use, a brief workup that can accompany the screening, and most importantly, what to do if a screen is positive. And screening, it's important to note, is differentiated from diagnosis. Screening is when there is a concern and we want to evaluate to see, is this concern enough that we should be doing additional evaluation, should be doing additional workup. Screening can be done by lots of different providers. Physicians can do it, nurse practitioners, physician assistants, other clinicians, all can take part in dementia screening. And it's important to note that you can utilize these different providers, especially advanced practice providers, to try to help integrate screening into a routine clinical practice. Because this is the thing that we often find is the hardest, is that we just feel like there's not enough time in a clinic session to do screening for dementia as well as all of the other metrics that we have to keep up with in terms of taking care of our patients. And so utilizing our staff and utilizing additional resources such as advanced practice providers to be able to take some of that time burden off can often really help in ensuring that we're doing screening regularly, routinely, and effectively. So as far as who can screen, this always becomes the question. And it's important to note that it doesn't have to be just the physician that does screening for dementia. Screening really can be done by anybody in the clinical setting. And many clinicians often find that they're too taxed or too time burdened to do every screening metric that we have under the sun. But what we're also finding is that there's a larger number of advanced practice providers that are really here to help ensure that the patients are getting the essential care that they need due to these taxes of time. And one thing that we often find is that the most effective and the most skilled practitioners that I've seen taking care of the screening of patients of dementia are really the advanced practice providers, the nurse practitioners and the physician assistants, who often have a little bit more time to be able to focus on these important matters and can really hone in and do it well. For instance, at our memory disorders clinic at UC San Diego, we have a phenomenal nurse practitioner who works with us and really helps augment the care of our patients with dementia. And our practice would not be able to function without her. The same is true in many primary care clinics for nurse practitioners and physician assistants. And it's important to note that you guys have the skill sets to do screening and to do it effectively, and often better than the physicians can. As far as why we care about this and why it's important, early screening is essential in terms of the detection and the management of dementia across the spectrum. More and more, we're starting to realize just how important it is. And it's because with early screening and early detection, we find that's when we can do the most good for patients. The earlier in disease they are, the more impactful interventions are in terms of lessening symptom severity, delaying entry into nursing home care, delaying progression of functional decline with the disease. Listed on the slide here are all the various things that have been detected as things that are highly beneficial in terms of early screening, is that we can address treatable health issues and reversible factors early, hopefully before they set stuff in stone in terms of cognitive decline. One thing I often tell my patients about is this next one, is that we can really help plan for the future while the patient is able to participate. For instance, once you've progressed to a moderate or severe dementia, you may lack the capacity to make important medical decisions about your care. And so you may not be able to fill out that advance directive any longer, or that post form, and have it be valid because it wasn't made at a time that you had capacity to make those decisions. And so having discussions of advanced care planning and end-of-life planning while the patient still has capacity is essential. And we can put a little bit more emphasis on that if we can detect some cognitive changes early on. It also allows patients to help plan for work, for travel, for leisure time, for thinking about, when do I want to take that vacation with the grandkids? When would be an optimal time to retire if I'm having some concerns about my memory and if it may affect my work? And then also, we see too that there are new medications starting to be made for the treatment of Alzheimer's disease. And the focus of those medications is really on the earliest stages of disease. And it's not even recommended to give them to Alzheimer's disease when it's in the later stages. And so detecting early can also help affect pharmacologic treatment for the patients. As far as thinking about the clinical stages of Alzheimer's disease, we know this is not a sprint. Alzheimer's disease is a marathon of a disease. It's estimated that from time of diagnosis, the average late onset Alzheimer's disease patient has a life expectancy of 10 to 12 years. Typically, the first 5 years or so of that can be spent in the mild cognitive impairment stage. And then we progress to mild to moderate to severe Alzheimer's disease over usually the course of the next 5 to 7 years. One thing of note is that we do have some cutoffs on the mini mental status exam for what defines mild, moderate, and severe disease, but these are not set in stone cutoffs because really the differentiation between mild cognitive impairment and Alzheimer's disease is not a performance on a cognitive test. It's the ability to do things, your functional abilities. And it's when function becomes impaired that we progress to Alzheimer's disease. So you could have a significantly impaired mini mental status exam and still technically meet criteria for mild cognitive impairment if those cognitive issues are not affecting your function in day-to-day life. So while we do have these MMSE cutoffs for MCI, mild AD, moderate AD, and severe AD, know that we take those with a grain of salt. Really what we're looking at is this progression in terms of functional issues. As far as thinking about causes of dementia, we know that there's a lot of them, but the majority of disease is Alzheimer's disease. And that's why oftentimes we spend most of the discussion focused on Alzheimer's disease. But nowadays, the term Alzheimer's disease and other related dementias, or ADRD, is being used commonly because we're realizing that we don't want to exclude all the other forms of dementia that we're talking about. When we are talking about screening, we're screening not just for Alzheimer's disease, but we're screening for all forms of cognitive impairment. The second most common being vascular disease. Probably actually the most common is mixed dementia, which is a mix of Alzheimer's disease and vascular disease, because we often do have significant vascular component when Alzheimer's disease is present. And of lesser numbers are the other forms of dementia with Lewy bodies, frontotemporal dementia, etc. One thing that's really highly recognized these days is that there is a large degree of inequity in terms of early detection of Alzheimer's disease. And this is one thing that we're hoping that more regimented approaches to Alzheimer's screening is going to help rectify, and that is that a lot of Alzheimer's disease goes unrecognized, and disproportionately so in lower socioeconomic backgrounds. 60% of underdiagnosed Alzheimer's disease occurs in high-income countries, whereas 90% of Alzheimer's disease goes undiagnosed in low-income countries. Almost 2/3 of Americans with Alzheimer's disease are women. It's also noted that older Black and Hispanic Americans are more likely than whites to have Alzheimer's disease or other dementias. And yet, despite that, has a higher prevalence of the disease going unrecognized. And so it's because of this inequity that we really are trying to do what we can to increase awareness and increase comprehensiveness of screening across all populations. And that's one thing that some government efforts to try to improve screening have really started to focus on. As far as when to screen and what these efforts are, we know that there are certain mechanisms in place that allow us to incorporate screening into a routine clinical practice in an effective way that also allows it to be coded for, captured, and reimbursed. Those over the age of 65 can be screened annually for cognitive impairment, but we can do screening on anybody that's having cognitive symptoms. For those over 65, though, some of these mechanisms that exist to try to help capture screening are the Medicare annual wellness visit and something called the cognitive health assessment. The annual wellness visit is something that we're seeing more and more routinely done across health systems, and it's something that anybody who has Medicare Part B is eligible for after their first 12 months and annually thereafter. And as part of the annual wellness visit, Medicare does recommend that some form of cognitive screening be performed. It doesn't define what the cognitive screening needs to entail, but it is recommended and required for the annual wellness visit to do some form of cognitive screening. And so if we're going to be doing a form of cognitive screening, practicing guideline-based cognitive screening can be helpful. And so that's what the bulk of this talk is going to be reviewing. For those who do not have Medicare but are Medi-Cal-only patients, they're eligible for something called a cognitive health assessment. And this is something that was enacted by the state of California just recently and is being educated upon by a group called Dementia Care Aware. And you can visit their website for information on that at dementiacareaware.org. But the cognitive health assessment is a specific dementia screening visit for Medi-Cal patients that they are eligible for as part of their Medi-Cal benefits package. As far as the actual algorithm and what to do when we are screening, we outline that here. The Alzheimer's Project of San Diego is a group of clinicians across really all the healthcare systems of San Diego. We have representatives from all of the major institutions who take care of patients in San Diego, from Kaiser, Scripps, Sharp, UCSD, as well as community practitioners, not to mention representatives from the from local government, from Champions for Health, as well as various Alzheimer's-related groups throughout San Diego, such as Alzheimer's Association, Alzheimer's San Diego, Southern Caregiver Resource Center, and more. And we exist as a clinical roundtable to try to come up with evidence-based clinical guidelines for taking care of patients with memory impairment. And most recently, we've updated our screening and our diagnosis guidelines to try to streamline and ease their use in clinical practice. And so today what I'm going to be talking to you about is a step-by-step walkthrough of these clinical guidelines for screening, the algorithm that we've come up with for how to screen. We have the full outline of it here. As you can see, it's a very busy slide, so we're going to take this step by step. So don't worry that you don't have to read all of this now, but this is available at our website, which you can access, that we'll have links to at the end for more detailed information. Screening, just like with any symptom-based evaluation, is something that gets done in clinical practice. And just like with any other symptom, whenever we're evaluating something as a clinician, we need to take a history and we need to do a physical exam. And so when we're thinking about screening, that's the way we want to break it down as well, is we need to get a history and we need to do a physical exam. So the first step of screening is taking a history. And when we're talking about screening, we're talking about a way to try to quickly get information from a patient in a concise and brief way to see, is there a problem here we need to investigate or not? So the structured history for screening for dementia is brief. We say start by asking a few brief questions to see, are there any cognitive concerns? We list 4 example questions here that you can ask. First, just, are you noticing a problem with your memory? Do you know or have friends or family commented to you that they have noticed a change in your memory over time? Oftentimes, patients will report no to question 1, but maybe to question 2, because we know the hallmark of memory problems is something called anosognosia, which is Latin for you don't know what you don't know. It's very common to not recognize memory problems in ourselves. And so sometimes asking how others are interpreting it can help flesh out and find problems that the patient may at first glance not recognize. Even better than that would be having family members in the room to give a corroborative history. It's not required at a screening visit. We do say that it is required at a diagnostic visit, but if you can have family there at a screening visit to give some extra corroborative information, it's going to increase the power and the certainty of if there are cognitive issues going on. A few other questions to think about. Do you think that your memory has changed over the past couple of years? Because, some people You ask, are you noticing a problem with memory? And they'll go, well, yeah, ever since I was born. And so a lot of people do have forgetfulness. Not all of us have the best memories in the world. Does that mean we all have dementia? No. What dementia or cognitive change is all about is that change word. It's has there been a change in cognition over time? And so identifying that with the patients is important, and so asking directly about it is important. In addition, we also recommend asking, are there any activities or tasks that you're having trouble completing? This is to assess for function. Is there some type of functional impairment related to the cognition? Some people may say, well, yeah, I'm having trouble opening jars because I've developed a little bit of arthritis in my hand. That's not what we're talking about here. We're talking about, is there functional impairment due to the cognitive problems? I'm having trouble opening jars because my pantry's always empty because I'm forgetting to go to the grocery store to buy more jars to put in my pantry. Once we've conducted that brief history, we have to pair it with an exam. And so as far as how to perform a physical exam for cognitive screening, the main thing we focus on is doing some type of objective assessment of cognition beyond just the patient's history report. What we typically recommend for this is something called the mini-cog, which is a brief cognitive screen that you can do to assess, are there objective cognitive problems going on. If there is an informant available, ideally you can also do an 88, which is a symptom-based survey. And again, so that's asking about symptoms. So it's more of a history-focused tool. But if the 88 is conducted of not the patient, but an informant, it has similar power to doing a mini-cog or even doing a mini mental status exam in terms of assessing for cognitive change. Many health systems have elected to start doing 88s routinely as part of their annual wellness visits. It is important, though, to note who it is that's filling out that survey, especially if the survey is administered as a pre-visit questionnaire. Making sure that you ask and review that 88 with the patients to see, was this done by the patient or by an informant, will help you be able to interpret, what does this mean? Can I trust these results or not? And it's also recommended to do some type of objective assessment of functional status, asking about IADLs or instrumental activities of daily living, as well as activities of daily living. And that's what we think about when we're thinking about the examination portion of screening. We'll go into that into a little bit greater detail, though. First up, the mini-cog. The mini-cog is something that's been found to be highly sensitive for the detection of Alzheimer's disease. It's about 80% sensitive with specificity ranging 60 to 80%, which is a favorable result compared to the mini mental status exam. It's not a surrogate for the mini mental status exam or other forms of cognitive evaluation tools, but it's much quicker than those. And so if we can do a mini-cog and they score normally on it, we can more likely rule out an issue here and avoid having to do the longer cognitive tests on patients. The 88, similarly, as I mentioned, has sensitivity and specificity above 80%, but only when it's administered to the informant, not to the patient. The 88 can be trusted if it's positive and a patient administers it, but it's less reliable if a patient administers it and a test negative, because again, with anosognosia, they may just say no to everything on the 88. Doesn't mean they don't have those problems. As far as what the mini-cog entails, it's really a two-step evaluation. First is a 3-word registration. They give you 6 different sets of words that you can use here. It isn't recommended that you make up your own words, but that you use the words that are listed on the slide. And that's because these words are meant to be words that are unrelated to one another, that you can't make kind of conceptual links to in your mind, so that way you're just de novo trying to remember 3 isolated words. So you tell them those words, you have them repeat it back to you. Make sure that they understand it, that they've incorporated those words and know that they're supposed to remember them. Then once you've done that, you move on and you have them draw a clock. You say, here, can you put in all of the numbers of the clock? And when they're done with that, say, put the hour and the minute hand to show a time of 10 past 11. It's recommended to use a pre-printed circle or to draw a circle if you don't have the actual mini-cog form for the mini-cog version of the clock. And then after you've had them draw the clock, you then say, hey, what were those 3 words that I asked you to remember earlier? And if they remember back and you'd given them version 1 and they said banana sunrise chair, they get 3 out of 3 points for remembering those words. In scoring it, you give up to 3 points for the word recall, 1 point per word that they remember without any hints. And then they get either 0 or 2 points for the clock. Either they draw everything right and they get 2 points, or they make a mistake somewhere on the clock and then they get 0 points. And the total score is out of 5. So you just tally up the word recall and the clock draw, and that's your total score. If you score above a 3, then that's counted as passing. A 3 or higher, that is. That's passing is counted as a normal score. If they score below a 3, so a 1 or a 2 or a 0, then that's failing on the on the mini-cog. As far as the 88, again, this is best if completed by the informant. And what we're looking at here is 8 different problems that patients commonly have with cognitive change. And we give them a score of 1 or 0 based on if they say, yes, they've had a change here, or no, they haven't had a change here. And if they score at 2 or more positive on the 88, then that's counted as a positive test. And so we have the full 88 here. As you can see, it's 8 different symptoms that we commonly have with dementia. Trouble with memory on a daily basis, trouble with remembering appointments, problems with judgment and executive planning, things like that. But again, these are really symptoms, so that's why we don't really think about the 88 as much as an exam maneuver, because it's really just a much more structured history tool. Once you've completed that history and exam, then you're done with the screening. Then basically after that, you just interpret results with the patient. If they pass, meaning that there hasn't been significant issues in terms of the structured brief history, their performance on the mini-cog or the 88 or both is good, and they haven't had any functional impairment, then you're done. You could say, at this point, it does not look like there is any concern for cognitive decline. Let's talk about some healthy aging tips that may help with prevention of cognitive decline in the future, but otherwise we can just repeat this again in a year unless new symptoms arise. If they fail, we then recommend moving on to this red section of the algorithm to assess for reversible factors that may be contributing to conduct a laboratory assessment, as well as to look for red flag symptoms. So we'll go into this in greater detail as to what all this means. First, I always say you'll never make a diagnosis of dementia the first time that you meet a patient. And the reason for that is that even if it looks like a duck and quacks like a duck, it may not be a duck. It may be a delirium. Delirium and dementia can look a lot alike. Delirium is an acute change in cognition, whereas dementia is a chronic progressive change in cognition. And so whenever we're looking at a change in cognition, we're seeing it in a single snapshot in time. So we want to make sure that it's not an acute change that we're dealing with and that it is a chronic progressive decline. And the only way we can do that is by screening for potentially reversible factors that could induce a delirium. And so when we're doing cognitive screening, if the cognitive screen is positive, we then want to make sure that we're excluding reversible factors before we move on to an evaluation visit to see, is there anything we can do to fix, correct, reverse these cognitive changes before we evaluate in greater detail. As far as what those screenings should entail, it's always recommended to do a screening for depression because depression itself can contribute to decreased memory recall, decreased attention. There is a higher incidence of later life depression. And so it's recommended to do some type of formal depression screening. If you're doing this as part of an annual wellness exam, that's already baked in because a depression screen is required for the annual wellness visit. And that requires that you do at least a PHQ-2, ideally more than that, to assess for any depression symptoms. In addition, other things to think about: poor hearing and poor vision. Really, any kind of sensory impairment can affect memory and should be assessed for and detected, reversed if present, or reversed to the best of our abilities if present, to see if it makes a change. Polypharmacy is probably one of the biggest things that we as geriatricians focus on, because we know that there's an increased incidence in cognitive impairment just in polypharmacy alone. Doesn't even matter if it's cognitively detrimental meds or not, but just that sheer pill burden itself, of which polypharmacy is defined as actually only 4 pills or more a day, has a positive association with cognitive impairment. So doing what we can to reduce polypharmacy if cognitive concerns are present has been found to be beneficial in terms of potentially reversing or lessening cognitive symptoms. And especially we want to focus on the lowest hanging fruit, any cognitively detrimental meds such as sedative hypnotics, sedative pain meds such as opiates, or medications with anticholinergic burden. Anything that blocks acetylcholine is going to block the hippocampus, which is going to affect cognition. So assessing for medications that have anticholinergic action also is important in screening for polypharmacy. Obviously looking for alcohol or substance abuse, because both of those things can negatively affect cognition, and assessing for that is important. Sleep is another major important factor. We see that sleep disruption can be strongly associated with cognitive impairment, especially things like obstructive sleep apnea. So making sure that we're addressing and assessing sleep, looking for signs or symptoms of sleep apnea as well as other sleep disturbances, and correcting if necessary is key. And then lastly, something to screen for the most common causes of of delirium, such as infections, urinary tract infections, lung infections, etc. Doing some type of screening for that is important. And the best way to do that is with a tailored physical exam to make sure that there's nothing clinically that is apparent in terms of an infectious sign, as well as doing reversible factor screening blood work. What's typically recommended in here is to do at least a CBC, a CMP, or a complete metabolic panel to assess renal and liver function and electrolytes, a TSH to assess thyroid function, vitamin B12, vitamin D. Syphilis is often included. It's usually recommended there that if you've never had a syphilis test before and you're sexually active, or have been sexually active in your lifetime, to do a one-time syphilis screen. And if you've had any new sexual partners, or obviously if you have any GU symptoms, to do another syphilis screen at that point in time. HIV often is in there as well, but again is a little bit controversial. A lipid panel and an A1C is often also included in the reversible factor screen, mainly because we know that high ASCVD risk can increase the risk of vascular disease. And so if we see that on a lipid and A1C panel that your ASCVD risk is high, then basically we can't exclude vascular dementia as a potential contributing factor. So it's usually recommended to get a baseline lipid and A1C as part of the screening laboratory tests. So after we've done the screening for reversible factors, if we have failed our cognitive screen, then we want to proceed to an evaluation. But another time we may want to proceed to evaluation, even if we haven't necessarily failed the cognitive screen, is if there are any red flag signs. And red flags are things that, if they're present, may be indicative of something more serious and something that may lead to problems imminently if not detected soon. What we're looking for red flags here is any disease that has developed before the age of 65 could be of greater concern for a more serious dementia syndrome beyond just basic late onset Alzheimer's disease. Additionally, if there has been sudden onset of cognitive decline, that is also considered a red flag. What's defined as sudden onset is disease that is developed suddenly over a period of 6 months or less. And a caveat here is that we often get family members coming in saying, "Doc, this all came on so suddenly." And I've seen a lot of patients that the second that you hear that, people think, rapid onset dementias, and they go down a workup of $1 million plus doing lumbar punctures for things like prion disease and autoimmune encephalitis. That may not be necessary, because we know that for family members, sometimes they don't really detect the cognitive changes until it's really glaring and in your face. And at that point, it seems like it came on suddenly, but it may have actually been slowly progressing over a period of time before that. So assessing with the family, did this truly come on in the past 6 months, or could there have been some signs earlier than that, can help us differentiate to see, is it truly a red flag or not. But there are many cases of these more atypical, rapidly progressive dementias. And so if we do see that there are signs concerning for a rapid onset in the last 6 months of disease, then that's another time to consider more rapid evaluation. Third red flag would be if there's been a sudden change. So, if things had been slowly and gradually and progressive declining and suddenly they're 10 times worse than they used to be, that would be another time to consider more rapid evaluation. Typically with any red flag symptoms, those are the times that we do recommend proceeding onward to a referral to a subspecialist for thoroughness of evaluation, and potentially needing to do advanced testing such as lumbar punctures to test for prion disease or autoimmune encephalitis, et cetera. But that's not necessary for most patients. So with most patients, if you've failed a cognitive screen and don't have any significant reversible factors, that's when we recommend proceeding to evaluation. If you do have reversible factors, we recommend treating those, then reassessing, and then proceeding to evaluation if the symptoms are still present after treating reversible factors. And then, of course, if there's evidence of severe depression beyond the capabilities of the primary care provider to take care of, that would be another time to consider outside referral, specifically to a psychiatrist. But one of the big questions that comes up after we do a screening visit is this question of, what do we do about this? Doc, I'm concerned about my memory. Sure, you're going to see me back in 3 to 6 months to do an evaluation visit, but what can I do in the interim? How can I help protect my memory? And now is probably the best time to have that discussion, because what we find is that this concept of what's called a brain health plan can really be most effective when these strategies are implemented early in disease. So right when patients are having concerns about memory, or even better, before they're having any concerns, is really the ideal time to start intervening. And so having some type of counseling with patients about what to do to try to help protect their memory is another important part of dementia screening. As far as what to practically advise, what I tell my patients every single week is exercise and get a hobby. They laugh at me, I laugh too. And then I talk about, no, seriously, that's what we need to do, because that's what the evidence supports. As far as getting a little bit more nitty-gritty about it, why? What is it about physical exercise that works? Whenever we look at any disease state, we find that physical exercise is positively associated with lower disease morbidity, with better functional status, with slower disease progression. And the same is true with dementia. What's recommended for physical exercise in dementia is to really stick with the AHA guidelines, aerobic exercise being the most key. What's recommended there is at least 150 minutes a week of moderate to high intensity exercise. This can be something as simple as going for a brisk walk for 30 minutes 5 times a week. In addition to aerobic exercise, it's also recommended, though, to add on a couple extra steps: muscle strengthening and balance training. And if we can focus on these 3 things and implement them into our lives, we find that it actually does have a positive association with slower progression from things like mild cognitive impairment to dementia, with slower functional decline within dementia, delayed entry into nursing home care, to a pretty powerful way. Some studies have even cited up to a 50% delay in progression of disease in mild disease or in mild cognitive impairment for progression to dementia. It's a little bit harder to study, so we aren't as certain on those numbers. But by and large, whenever we look at reversible risk factors for dementia, physical exercise is number one. As far as the muscle strengthening and balance training, the reason why we think about those is that really what we're wanting to do here is try to offset any functional impairments that could wind us up into trouble down the road. Muscle strengthening, for instance, it's recommended there to do at least 2 or more days a week for 20 to 30 minutes a time of some type of muscle strengthening. This can be lifting weights, but it can also be things like resistance training, doing crunches or climbing stairs or doing pool exercises against water resistance. You could actually kill 2 birds with 1 stone here and do your pool exercises against water resistance and do water aerobics, and that way you're getting your muscle strengthening and your aerobic exercise all in one. That's often more beneficial for the older patient who may have some joint issues that may preclude them from going for brisk walks for 30 minutes 5 times a week, for instance, and so sometimes can be better adhered to. In addition, balance training is recommended to be performed at least once a week, optimally more than that. But if we can get the patient to at least do it once a week, all the better. The best studied balance trainings are Tai Chi and yoga. I typically find myself recommending Tai Chi a lot more than yoga to my patients, especially in the more exercise naive population, because of the fact that it's a lower strenuous level of exercise, and it's easier to do if we do have any joint impairments or immobility or reduced mobility. As exemplified in the photo here is that, you can even do it in a wheelchair. You can do yoga in a wheelchair too. They do have a lot of chair yoga exercises. But balance training is increasingly recognized as a very important part of dementia prevention, because one of the biggest things that can cause a rapid change in somebody with dementia is a fall with a head injury. Because if you get a fall with a head injury, that could either cause direct damage to the brain, or it can induce a delirium, wind you up in the hospital, drop your functional abilities so that it's harder to recover back to a prior baseline. So anytime we can do what we can to reduce falls, the better off a patient tends to be functionally and cognitively. Healthy eating is important as well. This is a bit of a controversial one in that there hasn't been a single diet to date that has been associated with a delayed progression of dementia, but we know that eating healthy and eating a good heart-healthy diet can help prevent blood flow issues to the brain by reducing vascular disease in the brain, which can then help with dementia. More, what we find is that eating is more important than not eating. One of the biggest things that is attributed with a rapid decline in functional status in dementia is protein-calorie malnutrition. And patients with dementia are more prone to not eating or reducing their oral intake or having early satiety. And as a result of that, growing malnourished. So, it matters less what we eat, and it more matters that we eat. But if we're counseling on diet, of course, eating a proportioned diet with things like choosemyplate.gov that teach people how to get equal portions of food groups and reduce fatty content into their diet and things like that, great. It's probably going to be better than nothing. Another factor that is extremely important with protecting cognition is mental exercise. The more that we use our mind, the better our mind functions. And there have been certain factors that have been shown to be associated with later onset and slower progression of cognitive decline in the literature. These factors are having a higher formal education level, retiring later in life, as well as having higher baseline levels of cognitive activity. A lot of times what happens when I tell people that is they say, wait, I can't retire? There was a study that showed that there was an increased incidence of dementia post-retirement, but really what we think it is not that retiring is inducing dementia, but rather the post-retirement lifestyle is often not one of cognitive complexity. A lot of people after retirement spend a lot more time in front of the television. But we know that the more that we use our brain, the more that we force it to work through complex problems, the better our brain tends to function. And so after retirement, what we're looking for is doing something to offset and replace the level of cognitive activity we had when we were working with something else. And so as to what that could be, what counts as that, really that's everything that falls into what's called mental exercise. And as far as what counts as mental exercise, it's really anything that gets the mind thinking and problem solving. Some commonly used methods are all listed here: reminiscence therapy, cognitive stimulation therapy, music therapy, relaxation. This picture here is something called the Snoozland therapy, which is something that was created for patients with autism. And they've since tried adapting it to dementia patients. This was all the rage a few years back, but we haven't found that it's actually helped significantly in terms of cognitive stimulation for patients. It does provide calming environments, so it can help with later stage disease like behavioral agitation, but probably not as much mental exercise. And that's, I think, part of the problem with many of the structured therapies for mental exercise is that many of them are either too juvenile or too simple of an approach. And really what we're looking at more is this last one, creative activities. This is why I say kind of tongue-in-cheek that one of the most important things somebody can do is get a hobby. And the reason for that is that hobbies, by and large, are things that involve multiple steps of cognitive checks and balances. Even something that may not necessarily be thought of as a hobby or as a cognitive activity, say such as gardening, has a lot of cognitive checks and balances. You have to assess the depth of the soil that you need to dig into to be able to get the roots to grow. You need to assess the health of the plant and the color of the leaves and the texture and any vermin, things like that. So there's all these steps where you're thinking, you're assessing, you're analyzing, critically applying information. And so the more complex we can get like that, the better in terms of keeping our brain active and engaged. Some things have been created to try to help with this, and that's what is called brain games. There are a lot of brain games that are out there to try to help improve cognitive function. We find, though, that brain games don't do too much. We frequently see articles like this where the FTC sues another brain game for making false claims that they improve memory when they don't. When we actually look at the evidence for brain games, we find that it's very scattered. Most of the evidence shows that if you do a brain game over and over again, you're going to get better at the brain game as a result, but you're not going to think better as a result, because they're too simplistic of tasks. It's kind of like a learned pattern behavior. If you do it over and over again, you're going to do better at it. But since it's not a complex task, it's probably not going to form new thought processes, create new connections, etc. So really it's a matter of looking at something that activates more of the brain. Music memory is a good example of that. This documentary, Alive Inside, really tried to look into this with patients that had some advanced forms of Alzheimer's disease that had progressed to the point that they were having issues with language, unable to communicate significantly. But there was one patient that this neurologist had that was a concert pianist in his past. And so what the neurologist did is he found some music that the guy had recorded in his past and played the music to him. And when the music was playing, he goes, I remember when I made this, and engaged in conversation. And everybody's like, what's happening? This is somebody that normally can't even say his name back to us. And what had happened is that music memory is stored in a different part of the brain than regular memory. Regular memory is in the hippocampus, which is degenerating in Alzheimer's disease, but music memory gets stored in the deep parietal lobe, in a part of the brain that's relatively preserved in late onset Alzheimer's disease. And so this guy had spent a lifetime exercising that music memory center of his brain, learning music, playing music, interpreting music. And by doing that, it had beefed up that music memory center and caused neuroplasticity. So the nerves in it started connecting to other surrounding nerves, and it had built up some redundancy and backdoors so that when music memory was accessed later in life, it allowed him to have a backdoor into regular memory and engage in activities that he otherwise previously wasn't able to engage in. So it doesn't mean go out and learn an instrument, but it's a good example of what mental exercise is it's trying to build those back doors, trying to build those connections so that way, even if part of our brain is degenerating, we've got some redundancy. Socialization is another key thing that we've been finding is really important in terms of cognitive impairments and protecting cognitive health. The pandemic really showed us this. The amount of patients that we've seen coming in for cognitive impairment complaints after the pandemic quarantine have really skyrocketed. And it's not because the pandemic caused a bunch of dementia. What it is the pandemic removed social networks. How many times, for instance, have you taken your glasses and put them down and somebody said, hey, you forgot your glasses? But if there's nobody around to remind you forgot your glasses, you may be in the eye doctor's replacing your pair of glasses. By the time you do that 3 or 4 times, suddenly the eye doctor is going to be like, you may want to get your memory looked at. So what it is that by removing the social network, we remove the ability of others to serve as our external brain to help make up for our deficits that can help us function at a higher level than we otherwise would. And so the pandemic really showed us just how key socialization really is at protecting the memory. And so doing what we can to encourage socialization is probably going to be for your patient's best interest. As far as what can be done for that, there's a few different systems in place that could potentially help. Group activities are one of the biggest that I recommend. Basically, if you're going to do a Tai Chi class, for instance, actually do an in-person Tai Chi class where you have to go and socialize and do it with others instead of doing it on Zoom. For patients with kind of more significant cognitive impairment or who are in need of some respite or caregiving during the day, adult day services can be really beneficial as far as encouraging socialization. If possible, by resources and by family dynamics, multi-generational households consistently have been shown to help with preserving function, delaying entry in a nursing home for those with cognitive impairment. And most importantly, thinking about your community. There are lots of local resources to help with socialization. In San Diego alone, for instance, we have the local chapter of the Alzheimer's Association. We have Alzheimer's San Diego. We have Southern Caregiver Resource Center. We have community centers. We have social work groups that can help with linking patients and family members up with these resources. And so identifying some of your local resources that can help with this would be a huge benefit and also help offload the primary care practitioner from having to know all of this on their own and really kind of help utilize that team network to take care of patients. One question that always comes up when I give these talks is, well, what about medications? Should we give medications as at the conclusion of a screening visit if there's concern about cognition? It's important to note that the pharmacotherapy for Alzheimer's disease that exists is not, by and large, recommended for subjective memory complaints or mild cognitive impairment. In particular, I'm talking here about the more established drugs, the acetylcholinesterase inhibitors and memantine or the NMDA receptor antagonists. These are drugs approved for the treatment of Alzheimer's disease itself once it's reached the dementia stage, but is not recommended for mild cognitive impairment alone. There is this newer drug, lecanemab, and certain other agents in its class are also being sought for approval for Alzheimer's disease. And those are approved for more mild disease, but those aren't things that we would be talking about at a screening visit alone. Because there's a lot of qualifying information that has to be obtained to determine if you're eligible for one of those. And doing that requires a more formal diagnostic evaluation. Supplements are also something that patients will ask about. There hasn't been a supplement to date that has been found to be beneficial for cognitive impairment, but it's important to note that each medication, be it prescription or supplement, can carry an adverse effect with it that has to be balanced against the benefit. So we always have to think about what the patient's asking about and does it make sense given their other medications, given their other disease processes, before making a recommendation. Through the Alzheimer's Project of San Diego, we have this one-page sheet that's available in 5 different languages, specifically to try to help educate on all these different things involved in a brain health plan. We call it our Healthy Body, Healthy Brain handout. And this handout is meant to be distributed to patients and can be kept in your clinic. You could access it on our website. And it specifically goes through talking about all these different reversible and modifiable risk factors for Alzheimer's disease, and talks about both what to do and a little bit about the evidence behind it for the patients to try to help educate them. Once we've done all of this evaluation, this screening visit, and we've established patients that we may be concerned about that should move on to further testing, the next step after we've had this discussion of healthy aging is to have them come back in for an evaluation visit. And this is a more targeted visit dedicated to a greater understanding of what their cognitive issues are, quantifying it, and trying to start coming up with a diagnosis of why are these things occurring. We obviously don't have time to discuss that in this lecture, but you can find that information as to what an evaluation visit entails through our group, the Alzheimer's Project, and you can access our website here at championsforhealth.org/Alzheimer's. On this website, we have, beyond the discussion of screening that we just did, a full clinical guideline that goes into not just screening, but also how to evaluate for Alzheimer's disease and other related dementias, and importantly, how to manage it, not to mention how to discuss a diagnosis with a patient and what to discuss at time of diagnosis. Beyond the clinical guideline, we have other information on that website that is extremely helpful to the primary care provider. And that includes current and updated information about new things involved in the treatment and the care of Alzheimer's disease, such as information on these new monoclonal antibodies for the treatment of early stage Alzheimer's disease. We also have a link to 8 different webinars that are available for free CME credit through the Doctors Company that go into greater detail about each of the different subjects that the Alzheimer's Project focuses on that you can learn more about. And most importantly, thank you all for being here today, and thank you all for the care that you provide to your patients, as well as for the effort that you're taking to expand your knowledge to be able to better help your patients. I hope that today's lecture has provided some extra ammo for your tool belt of how to screen and how to take some interventions when a patient comes into you and says, "Hey, I've been a little concerned about my memory." But thank you all again so much for being here.